Hello friends, welcome to PW MedEd next, and INICET is around the corner, and we will take this opportunity to take up some important previous year questions, mainly from the last few 1 or 2 year of MCQs we are going to check, and we are going to do as much as possible in this 1 hour long session, right? So it is going to be a quick revision of the important points from INICET previous year MCQ. Okay, so PYQs we are going to discuss. So let's have a look at the first question, right? So identify the wrong statement regarding the period of gestation or EDD calculation, right? So all of us know how to calculate EDD using the Naegeli formula and everything. Now they are also asking you in depth about this, right? So let's have a look. First trimester ultrasound is the best assessment. That is true. That is a true statement, right? So ultrasound done early on in pregnancy, first trimester, is the most accurate assessment of gestational age or for EDD calculation. EDD is calculated from the last day of menstrual period. That is a false statement, right? EDD is calculated from the first day of menstrual period, not the last day of menstrual period. Okay, and this is the last menstrual period that had come, not the missed menses. Keep that in mind also. Okay, so this is your wrong statement straight away. In an IVF pregnancy, day of embryo transfer or day of fertilization is needed to calculate the POG. That is also a true statement. This is something that I will also give you out. And look at option number D. Crown rump length is the best measure of period of gestation in the trimester. That's also correct. So first trimester ultrasound, we see crown rump length measurement or the CRL. This is also a true statement. So the wrong statement here is option number B. All right. So remember here for EDD calculation IVF pregnancy, this is the logic that we use. The logic is, if you have a look at it, counting from the first day of last menstrual period, okay, the day the bleeding started, and this is somewhere the periods were missed. This calculation is accurate only when a woman has regular 28-day cycles. So if you have regular 28-day cycle, then this is where somewhere fertilization took place, isn't it? So this is about 14 days. It's about 14 days. So if you have a look, embryonic development or the embryonic age begins from the moment the embryo is conceived. That is from fertilization. Post fertilization, embryonic development starts, and full embryonic development takes 2 days. That is why when we take EDD into consideration, EDD corresponds to 280 days. Why 280 days? Because we have to add 14 days, isn't it? We have to add these 14 days also when we are counting from the first day of LM, right? So EDD corresponds to exactly 40 weeks, 40 completed weeks, that is 280 days, right? Now, when we are going to have IVF conceived pregnancies, then we can have this date of fertilization. Okay, fertilization is done in the lab. So the same day the eggs are retrieved, that is the day the fertilization is done in the lab also. So if you're having a fresh cycle, then egg retrieval rate or the fertilization day, that's the same thing that we have. To it, we can add 280 days to arrive at the calculation expected date of delivery. Okay? So from here, we'll have the fertilization date. To that, we will add 266 days to arrive at the EDD calculation in a fresh cycle. Supposing in IVF pregnancy, we are having frozen embryo transfer. So most of the times we are doing embryo transfer of the third day frozen. 3 days worth of embryonic development has already occurred in the lab also. So that has to be accounted for. So you will have the embryo transfer date. The day the embryo was transferred inside the uterine cavity, 3 days of growth has happened in the lab, right? So to the embryo transfer date, we are going to add 2 days to arrive at the EDD calculation. So this is the logic, and this is how it is used. Okay. Now let's have a look at the next question. A lady presented with 6 weeks of amenorrhea with mild pain in abdomen and moderate bleeding per vaginum. Her UPT is positive. Ultrasound abdomen reveals no gestational sac, no free, right? So we don't know where is the location of the pregnancy, right? So this becomes a pregnancy of unknown location, isn't it? With some symptomatology. Symptomatology of mild pain in abdomen, moderate bleeding is also there, and pregnancy test. but as of now, we don't know where the gestational sac is because we are seeing nothing on ultrasound, not even seeing any free fluid. Why they are commenting on free fluid? Possibly because of a ruptured ectopic where they, that is the concern here. So what shall be the next step in the management? So we are thinking that this is pregnancy of unknown location, and it could be a very early intrauterine pregnancy, right, which is so small as of now that it is not visible. It could be a failing intrauterine pregnancy, or it could be an ectopic pregnancy, right? So these are the possible differential diagnoses. Okay? Don't say this is a complete abortion. Why? Because there is no history given of, passage of fleshy mass. Even if there is passage of mass, the history like that is there. We don't know what fleshy mass was passed. Was it a double cast? We cannot be 100% sure, right? So as of now, the management would be, the next step in management would be to perform a beta HCG test, a serum beta HCG, be very precise. Okay, follow up with serum beta HCG, and we can keep following up, every 48 hourly to see the trend of serum beta HCG. That would be the best course of management. No medical management is required at this point in time because we don't know where the pregnancy is. What kind of medical management will we do, and for what? Right? What are we going to do suction evacuation for? Inside the uterine cavity we are not seeing anything, right? And why terminate a pregnancy? Why terminate a pregnancy? To terminate a pregnancy, one has to first know the location of the pregnancy. Where is that pregnancy? Right now, best course of action is to follow up with beta HCG and serum beta HCG. And you remember here that when you have doubling of serum beta HCG levels, doubling of serum beta HCG levels, it goes in favor of a intrauterine pregnancy, a healthy intrauterine pregnancy, right? When you have plateauing levels, it goes in favor of pregnancy. And with failing intrauterine pregnancies, the levels are going to fall very, very fast, okay? And they're going to fall at least more than 40 to 50%, okay? Keep that in mind. So when we follow with serial serum beta HCG, it has to be repeated 48 hourly to see the trends of the HCG, right? So that is why the answer in this question is option C. Now, let's have a look at the next question. Which of the following is not done in active management of third stage of labor? Okay, so active management of third stage of labor is routine practice. You all know that it is done for prevention of PPH. Remember these important points. Now let's have a look at the options, right? So you know that uterotonic after delivery, drug of choice is oxytocin, 10 units of muscular, right, is given as soon as the delivery of the baby. This is the most important step, okay, the uterotonic part, right? So that is done. Controlled contraction is done as a method for delivery of placenta. Ideally, yes, according to WHO, it is intermittent uterine tone assessment, but yes, uterine massage is according to the Government of India recommendation. So uterine massage fits. Okay, uterine massage fits in active management of third stage of labor, but something that we don't do and something that is not required is early cord clamping. Until and unless there is an indication for early cord clamping, that is something that is not routinely done. What is routinely done? Routinely we are going to do delayed cord clamping, right? Delayed cord clamping is routine. So that's why answer in this question is early cord clamping. This is not done routinely in active management of third stage of labor. Okay, now let's have a look at the next question. Now, dose of carbetocin used in AMTSL, AMTSL stands for active management. Carbetocin is a synthetic oxytocin. Remember this. Okay? Carbetocin is a synthetic oxytocin. The oxytocin that comes under the trade name syntocinon that we use in our labor rooms, right? That oxytocin is the recombinant oxytocin. Okay? And that oxytocin, which comes under syntocinon, synto, right? That is basically a non-peptide. Okay? And this synthetic oxytocin, which is carbetocin, it is a long acting analog of oxytocin, and it is an octapeptide. Okay, it has the same action profile. It has the same side effect profile also, except for the difference that it is long acting. That's an important point, right? So the effect lasts for about 3 hours once this is given. In which dose, that is the question. So they ask you the dose. The answer is 100 micrograms over 1 minute, and it can be given as a slow IV injection, or it can be given as an IM injection also, right? So remember this oxytocin analog, which is carbetocin. Okay, it is recommended to be used in active management. It can be used in place of the recombinant oxytocin or syntocin, right? So remember the important pointers about the uterotonics. This is a very, very important chart for your. They ask you a lot of questions about it, okay? So oxytocin, the one that we are using, the dose is 10 units IM, or IV infusion can be given. But please remember, oxytocin is never given as IV bolus, because it can do dangerous side effects like that of sudden hypotension, tachycardia, can even precipitate myocardial infarction, right? So for active management of third stage of labor, the dose I have told you is this. For PPH, that is postpartum hemorrhage, it is in higher dosage, 20 units in 500 ml, and IV infusion is given. And side effects like hypotension, tachycardia, they are generally otherwise uncommon. Oxytocin is pretty safe, but these are more likely with IV bolus. Keep that in mind. And water intoxication is a very rare side effects, and it happens with very large dosages when oxytocin for very prolonged duration of time, and in very high dosage. This is something that is very, very rare. And this water intoxication with oxytocin is actually the antidiuretic action that oxytocin has in very high dosage, right? Then remember, methergin is recommended for AMTSL. It can be used, but it is not preferred, okay? Methergin can be used for active management of third stage of labor, preferred because it is risk of retained placenta. So in PPH, it can be used in the same dosages as well. Remember, the side effect profile of methergin is extremely important for hypertension, eclampsia. These are, contraindications for methergin use, because it causes hypertension, and like I told you, in placenta also. So remember these contraindications with methergin. It is a direct that can be, so hypertension, preeclampsia, heart disease, peripheral vascular diseases, Rh negative pregnancies, patients where methergin used. And also remember that when one twin delivers and there is another twin along the way to deliver, there's a delivery of second twin is pending, then also one can use methergin. So remember that also, if delivery of the second twin is pending, then we cannot use methergin, obviously, right? Because there's a fetus yet to deliver. Then you have misoprostol. Misoprostol is PGE1 analog. The advantages of is that it is in the oral form, it is in the tablet form, right? And it can add room, so it is much cheaper also, right? The dose for AMTSL is 400 to 600 microgram orally as recommended by the WHO, and 800 microgram sublingual. When fever is the most common side effect, apart from that, yes, tend to occur. There are no specific contraindications for as well. Carbetocin, like I told you, synthetic oxytocin analog, can be given in active management. Very important point, it is not recommended by WHO in PPH patients. Keep that in mind, right? Now, syntometrine is a fixed dose combination of synto, that is oxytocin, metrine, that is methylene. Okay? It can be used in AMTSL, but it is not recommended to be in postpartum hemorrhage. Then carboprost is also coming emabate. This is alpha, right? It is not recommended, it's not recommended in active management stage of labor, but it is recommended in PPH cases, right? So 250 micrograms intermittently every 50 minutes can be given for a maximum of 8 doses. So all in all, the maximum dose in one go or in 24 hours is 2 milligram is the maximum dose, and that is also a question in your exam, right? Side effects, diarrhea is the most common side effect. Apart from that, nausea, vomiting, and bronchoconstriction. And remember, very, very important point for MCQ, they ask you what is the absolute indication, and that is bronchial asthma. This is it. This is one condition where carboprost is not used. That's very, very important point. Note. Now, in your exam, they also ask you this, that they can give you a profile like, which among the following drugs is used, not used for PH, and so on and so forth. So this chart is going to help you. Remember, very, very important point, that PGE2 analog, that is dinoprostone. Okay, dinoprostone, keep in mind, is not used, not recommended to be used in AMTSL. We don't use it there. No, even we do not use it in PPH patients also. Where do we use PGE2? PGE2 is used as a cervical ripening agent. Cervical ripening agent. We use it in induction of labor. That is where we use, okay, dinoprostone PGE2 analog. We don't use it for AMTSL or H. Must know point. Remember that. Okay. Now also remember regarding misoprostol, widely in obstetrics for different indications, and dosages of misoprostol are important. So we already talked about the dosages of misoprostol in AMTSL and PPH. Remember these two extra points. In first trimester MTP, the dosage of misoprostol is 800 micrograms. Okay, and please keep in mind that misoprostol is given in combination with mifepristone, medical term pregnancy. Remember, mifepristone antiprogestin, and 48 hours later followed by dose of misoprostol. So dose of misoprostol for first trimester MTP 800 microgram, second trimester MTP 400 microgram every 3 hours, maximum 5 doses are from the government of India recommended. Right. Also remember that misoprostol in these situations given by all, right? So we can give it orally, we can give it sublingually, we can give it vaginally, we can give it buccally. All routes are there, but yes, most preferred is sublingual, right? So remember this important point also. And as far as induction of labor at term goes, induction of labor at term goes is an off-label use of misoprostol. We commonly use it, but it is an off-label use of misoprostol, induction of at term, and therefore the dosages are also very varied. Some people use in 25 microgram dosage, very less dosages are used at term. So keep that in mind. Off-label use of misoprostol. Now the next question. A 50-year-old woman presents with abnormal uterine bleeding for 2 years. What shall be the next step of management? Right. So clearly, this is an often repeated question, my dear friends. So I'm sure that you all know the answer to this. Right. 50-year-old, or perimenopausal age group, or even postmenopausal woman, that matter. Right. The concern is endometrial hyperplasia. The concern answers some sort of endometrial has to be made. Okay, but very, very important point, and I keep telling you again and again, that when you have any abnormal uterine bleeding, have any postmenopause, heavy menstruation, any kind, always begin with the pers speculum examination. Don't forget that. Okay, as a pointer, don't forget that. Always begin with pers speculum examination and evaluate the cervix also, because in our country you see cervical cancer is very common. So always look at the cervix also. Keep that in mind as well. So as of now, in this question, she's having abnormal uterine, no other information in this question, but maybe yes, they could provide you this extra information. Cervix looks healthy, let's say, or the clinical examination is unreliable. What shall be the next step of management? Before trying any treatment in this, we have to exclude endometrial. So we have to go for endometrial, and we can also combine it with endocervical curettage as well. We can combine it with endocervical. So that is the answer here, endometrial aspect. Hysterectomy, straightforward, don't go for it. We have to have a diagnosis. We have to have an indication. Before any hormonal treatment, ideally we should be going for endometrial aspiration, particularly in this age group as well. Very, very important. So Mirena or LNG IUD is not going to be the preferred management next step of management, or progesterone in any other form will also be not the preferred or the next step in management. First rule, very, very important, endometrial aspiration or answer, right? So remember here, very, very important point also, and what are the indications for endometrial aspiration. So when you have a postmenopausal woman, postmenopausal bleeding, okay, then please remember here that it is the investigation of choice for, and more so if your transvaginal sonography, so endometrial thickness more than or equal to 4 mm, right? The cutoff is 4 mm. That's a very, very important MCQ But in reproductive age group women, in reproductive age group women, then the cutoff of endometrial thickness for endometrial aspiration, then your cutoff for ET is going to be more than or equal to 10-12 mm. Keep that in mind. Or let's say when the age of the woman is more than 40 years and she's complaining with abnormal uterine. So broadly, these are the three important remembering where you are going to come in endometrial aspiration. Keep that in mind. Now let's have a look at the next question. A woman presents with secondary amenorrhea. Secondary amenorrhea, meaning that she had not menstrual cycles, and secondary. It by definition means amenorrhea or 3 consecutive cycles or duration of 6 months, right? All of the following can be responses except fairly straightforward question. Maybe you can get confused with Turner mosaic. Very important. So Coleman syndrome, remember the answer to this question is Coleman syndrome. Coleman syndrome is always going to cause primary amenorrhea, right? Why? Because Coleman syndrome is congenital deficiency of GnRH. Congenital deficiency of GnRH neuron. So it always presents with primary amenorrhea. There is also deficiency of factory neurons. That is why there is anosmia or hyposmia. So understand that since there is congenital deficiency in RH hormones, it is always going to cause primary amenorrhea. It is not going to cause secondary amenorrhea, right? Fragile X, not permutations, premutations. Fragile X premutations, they are associated with premature ovarian failure. Or ovarian failure. Also called as premature ovarian insufficiency. They can present with secondary amenorrhea. Turner mosaic is rare actually. So, all in all, Turner syndrome, is 45XO. That is what Turner syndrome is. Turner mosaic is 45XX, some cell lines, 46XX, some cell lines are normal, and some cell lines are 45X karyotype. So, this is a mosaic karyotype, right? These women may menstruate. They may menstruate. They may have some ovarian follicle left. So they could possibly present with secondary amenorrhea if they have menstruated earlier. That's why Turner mosaic is not the answer. Okay, Turner mosaic could possibly present with secondary amenorrhea. Sheehan syndrome, is anterior pituitary. Anterior pituitary, the classic syndrome which has anterior pituitary necrosis. There is history of severe PPH, and that is why there is GnRH deficiency because of gonadotropin deficiency, right? Because of anterior pituitary process, there is failure to lactate also because of deficiency of prolactin. Prolactin also comes anterior pituitary. So Sheehan syndrome presents with secondary amenorrhea also. So a woman presents with secondary amenorrhea. All of the following conditions can be available except Coleman syndrome, which only presents amenorrhea, right? So again, I want to remind you, dear friends, that with INICET and in the couple of years that you see the past, they're asking you very in-depth questions. Amenorrhea. They are, repeatedly asking primary amenorrhea and endocrine. That becomes a very, very important area to revise and conceptually grasp all. Like for instance, have a look at this. Right, they've asked this question, such match the following kind of question will look difficult, from the to look difficult to begin with, but when you have such questions, always go ahead and think, what are you sure about? There's possibly one option that you will be definitely sure about, and then you start eliminating. For instance, you have to match these following disorders with their hormonal. Okay. And one hormonal profile I am sure you know by heart by now is Asherman syndrome. So Asherman syndrome is, fibrosis and scarring in the uterine cavity, right? The endometrium is destroyed, the endometrium is damaged, fibrotic, right? Uterine synechia are there. The problem is with the uterine lining, right? There's nothing wrong with the ovaries, there's nothing wrong with the hypothalamus and pituitary. You all know that with Asherman syndrome, the hormonal profile is actually normal, absolutely normal. So Asherman syndrome, normal FSH, normal LH, and normal estradiol, right? So option C matches with option number D. Option C here matches with 2, right? So this thing we are sure about, right? So let's have a look. C. So see, I have always actually eliminated all the rest of the options. maybe in exam you may be able to eliminate two. Then also your job becomes very easy to attempt such attempt by elimination. That way you will be quicker in attempting such questions. So have a look here. This is C matches with 2. Asherman syndrome matches with normal FSH, LH, normal estradiol. That's your answer. Let's have a look at the other option. When you have premature ovarian failure, then ovaries are depleted of its follicles, so low estradiol, right? And as a result of which there is high FSH, high LH, right? Just like that happens in menopause, similar to that. We have Sheehan syndrome. Sheehan syndrome is anterior pituitary gonadotropins decrease, low FSH, low LH, and because of that, there is low estradiol. So Sheehan syndrome matches with B matches with 1. All right, and in PCOS matches with 3 here. Okay, so in PCOS, you can see here we have low FSH, we have high LH, and we have normal estradiol. And remember here, yes, in PCOS, the LH is to FSH ratio is, yes, generally more than 2 is to 1, but this is not a part of the diagnostic criteria. Please remember that for the diagnostic criteria of PCOS, we are checking serum testosterone. Remember that also. Serum testosterone is a part of the Rotterdam's criteria for diagnosis of PCOS. So LHFSH levels, the abnormality in LHFSH levels is part of the diagnostic criteria. This is also important to remember. Okay. Now let's have a look at the next question. Again, they have been asking questions on primary amenorrhea, deep into primary amenorrhea. And look at this. In cases of complete gonadal dysgenesis, what type of mutation will be seen in the SRY gene? So they're particularly asking you about a situation, Bayer syndrome, right? Where the karyotype is 46XY, right? But the phenotype is female, right? So it is basically a genetic male, but with the phenotype of female. Why? Because the Y chromosome, has a gene called the SRY gene, right? SRY gene is located on short Y chromosome, right? It brings about the cascade of events that brings about the development by potential gonad in testes. That is what it does, right? So mutation in this SRY gene could be responsible for a type of dysgenesis called as syndrome. So the most common mutation is basically, however, there can be other types also in all this syndrome in itself there. So let's highlight the important point of gonadal dysgenesis. See, if you look at gonadal dysgenesis simply means that embryologically, right, in the fetal life, what happened is that the gonads, they failed to develop, right? Gonadal development did not occur in life, right? So most common type of gonadal dysgenesis is actually Turner syndrome. Right? Turner syndrome is also a gonadal dysgenesis. 45XO is the most common type. Turner mosaic rare can be there. Turner mosaic can also rarely there can be Turner mosaic also, right? So the gonads don't develop, they're dysgenetic or streak over, right? Then there are other causes of gonadal dysgenesis also, like 46XX gonadal dysgenesis there, and 46XY gonadal dysgenesis is what we call as what we call as Swyer syndrome, right? So these are what we call as pure gonadal. By pure, it simply means that the karyotype is not mixed. Karyotype is not mosaic. That is what pure gonadal dysgenesis means. And you have mixed gonadal dysgenesis. This is extremely rare. 45XO slash 45XY chromosome. There, this is mixed gonadal dysgenesis. It is very rare. Phenotype could be male. The phenotype could also be ambiguous depending upon any androgen produced in the fetal life by these dysgenetic gonads. So that depends. So we're not going to talk about this. It's rarely asked, this mixed gonadal dysgenesis. Knowing the name is enough. But what you need to remember here are mainly concerned above top three type of gonadal dysgenesis, right? What is important to know about gonadal dysgenesis is that whatever be the karyotype, it 45XO, be it 46XX, 46XY, you know what happens is that the uterus is present. Very important point to present. Now the uterus, normal uterus, or it could be a hypoplastic uterus, as we see in Turner's, but the uterus is present. Okay, the phenotype is also female. The phenotype, the external phenotype is also female. The external genitalia is also female, right? And the child is going to be born and brought up as female. But what is the problem? They are going to present with delayed puberty. That is the important, right? So, patients with gonadal dysgenesis, they are actually born and brought up as females, phenotypic females. They are actually identified once they reach the age of puberty and they have delayed puberty. So, delayed puberty, they have absent breast development. Remember, they were phenotypic females born during the time of puberty. Breasts won't develop because your estrogen deficiency is there, isn't the gonads are dysgenetic, so there is estrogen deficiency, right? The uterus is present, the gonads are simply weak gonads, right? And it's very difficult to say just based on ultrasound whether they are streaked ovaries or whether they are weak dysgenetic testes. We cannot really be sure that, but nonetheless they are streak, right? And they have hypergonadotropic hypogonadism. Cause of estrogen deficiency, what will happen? Their FSH and LH ratios, FSH and LH levels actually, FSH and LH levels be high, they are going to be increased. So hypergonadotropic hypogonadism. So gonadal dysgenetic patients are going to share this profile. Okay, so these patients of gonadal dysgenesis, right, are going to have a similar clinical profile. Similar clinical profile, like very similar clinical. So how are you going to differentiate? That is the question they ask you in exam. Okay, so in exams, make a note that if you have short height and they're giving you any stigmata, plus minus stigmata of, I'm going to talk about that also, or they mention a hypoplastic uterus or infantile external, right? This is most likely Turner syndrome. If the patient is tall and the uterus is present, it can be the other forms of gonadal dysgenesis. It can be the other form of dysgenesis. To know for sure, you have to have a karyotype. You will know for sure, you will make a diagnosis based on the karyotype. That is how we are going to diagnose. Gonadal biopsy is something that is not generally done. Now remember here other key pointers that gonadal dysgenesis, they've reached the age of puberty, are going to need hormone replacement lifelong, isn't it? They're going to need hormone replacement lifelong. Also important to note here that karyotype, knowing the karyotype is really important because you could have this kind of gonadal dysgenesis, mixed gonadal dysgenesis. You could have 46XY kind of gonadal, right? So when you have a gonadal dysgenesis with Y chromosome present, when you have a gonadal dysgenesis with Y chromosome present, remember here that gonadectomy has to be done because these gonads, these dysgenetic gonads, which could be dysgenetic testes, if they are dysgenetic testes, they are undescended dysgenetic testes and they are at increased risk of having malignancy later on in life. So if there is a Y chromosome present, then gonadectomy has to be done as soon as diagnosed. Okay? Keep this in mind. These are very, very important QMCQ to help you attempt questions because they're framing a lot of questions on adult dysgenesis also for you. Very, very important. As far as so these women, these women will have, okay, given them lifelong hormone replacement therapy to take care of their hormone status because they have estrogen deficiency, they have no source of body, so obviously over their lifetime they are at increased risk, they're increased risk of, they do need lifelong hormone replacement, right? Other than that, they have a multidisciplinary care approach required, so I'm not going to go into too much. But for MCQ purpose, they ask you about pregnancy. Okay, can these young girls, or can these women with gonadal have a pregnancy, right? So with Turner syndrome, remember there's a hypoplastic uterus. Okay? So, and they have streak ovaries, right? They have streak ovaries. So neither they have follicles nor they have a uterus capable of bearing a pregnancy. Pregnancy for Turner syndrome is very rare. Moreover, even if they even if they have a normal, they have so many other stigmata and medical complications that pregnancy is high risk for them. So the question of pregnancy in Turner syndrome is very unlikely. Okay. However, yes, if you have these other forms of gonadal dysgenesis, like your Swyer syndrome, or like your 46XX gonadal dysgenesis. So with Swyer syndrome, or if you have the other kind like 6XX type of gonadal dysgenesis, have, so basically, if there is a uterus that is present, if there is a normal uterus that is present, then pregnancy is possible. Pregnancy is possible by IVF with oocyte donation. IVF with oocyte donation. That is one possibility that can be looked into, or that can be attempted. That is just for MCQ. That in mind. Pregnancy is possible, IVF with that completes actually a very, very high yielding point regarding on MCQ. Okay. Now let's have a look at the next question. Again, in recent INIC, they asked this, that which of the following investigations is not done for evaluation room? Now, see, for attempting this question, you know what all other things can be there in Turner syndrome patients. Okay, so cardiac evaluation is required because they have cardiac malfunction, okay, and they can have cardiac complications. Cardiac evaluation is done, right? They are at increased of autoimmune disorders also. They are at increased risk of hypothyroidism, increased risk of diabetes mellitus also, right? So OGTT is done. Okay, they do also have increased risk of having sensory neural hearing. So audiometry is done. However, anti-nuclear antibodies straight away, this is something that is generally not done in evaluation patients. Okay, so that's your answer there. So remember here the stigmata for very, very important. The short stature is the most important when we talk about Turner syndrome. Okay, because the other stigmata may or may not be there, but they are always short. That is what it means. Okay. And intelligence is mostly normal. You can have a look here. The diagram is also there. Web neck, low set ears, widely spaced nipples, shield chest, cubitus valgus, infantile utopia, hypothyroidism, serious anomalies they have, right? Most commonly they have bicuspid aortic wall. They can have hypertension. Renal anomalies also, they can have different kinds of, most commonly they can have also, right? And osteoporosis is a long-term concept, estrogen deficiencies. Yeah. Right. So these are important pointers, must know pointers that you should be aware of regarding Turner syndrome. Okay. Now let's have a look at the next question. A 16-year-old girl presents with absent breasts, right? So primary amenorrhea. Examination shows widely spaced nipples, web neck, stage, Tanner grade 1 breast. You given in the question the stigmata, right? Ultrasound shows streak ovaries. Investigations show raised FSH, raised LH, reduced estradiol. Now you know you can straight away answer what is the diagnosis. The diagnosis is Turner syndrome. Points in favor of diagnosis. Okay. So from here also, let's understand the other options. Let's eliminate the other option. So Coleman syndrome is congenital deficiency of GnRH, right? So if GnRH is deficient, then in Coleman syndrome there is going to be FSH and LH deficiency. They are going to be decreased, and estradiol is also going to be low. Okay, remember that. And the stigmata is not going to be there. So even Coleman syndrome, they have absent breast development. They have absent breast development. but the hormone profile is going to be different, right? With androgen insensitivity syndrome, what is the problem? The androgen insensitivity syndrome, you know here that the problem is that they have absent uterus. Okay, MRKH syndrome, they also have absent uterus. When we say MRKH syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome, Mullerian agenesis is a part of this MRKH syndrome, right? Mullerian agenesis is a part of this MRKH syndrome. Mayer-Rokitansky-Kuster-Hauser syndrome, the other counterparts are hemivertebrae or scoliosis and renal agenesis, right? So these are the triad included in MRKH syndrome. So Mullerian agenesis, you know, absent uterus is there, absent uterus there, right? And the hormone profile is going to be normal. Okay, breast development is, this was a straightforward question. Okay, this was a straightforward question where your answer is Turner syndrome. But you have to know the flow chart for the diagnosis primary clinical question. So let's quickly revise these criteria. So if you have primary amenorrhea, the breast development is there, the uterus is also there, right? If there is any signs and symptoms suggestive of cryptomenorrhea, hidden menses, right? There could be an abdominal lump also. Abdominal lump could be there, plus minus, because of blood filling inside the uterine cavity, right? Hematocolpos could be there, hematometra could be there, right? Even on per rectal examination, bulge could be felt, bulge felt could be there on per rectal examination, probably the hematocolpos. So similar profile is going to be there. There are two possibilities, right? If you have a bulge at the introit, bluish bulge at the introit, is the diagnosis imperfect hymen. The diagnosis is imperforate hymen, right? At the most, one can do an ultrasound to see the amount of pelvic collection. Okay, there is no need to do a hormonal profile. Your hormonal profile is going to be normal. There's no need to do a hormonal profile, but your hormonal profile is actually good. Well, the treatment is to give a cruciate incision, right, and let the contents. The other possibility is a transverse vaginal septum. In transverse vaginal septum, the local examination is usually the bluish bulge at introit, right? And if when we are doing a per rectal examination, the hematocolpus will be higher up. The hematocolpus will be higher up. So with imperforate hymen, the hematocolpus is along the entire length of the vagina. With transverse vaginal septum, depending upon where is the location of the transverse septum, right? Depending upon where is the location of the transverse septum, which is mostly in the upper part. Okay, so higher up, the hematocolpus will be higher up. It will not be along the entire length of the vagina. That clue could be there. And local examination is usually. Ultrasound at the most will help you. Ultrasound will at the most tell us if there is a collection, if there is this collection of hematocolpus or hematomet. But the best investigation to confirm the diagnosis is an MRI pelvis, and the treatment is going to be septum. Okay, so these are important pointers. Next is, if you have primary amenorrhea, breast development present, the uterus is absent, and there is a blind vaginal pouch. Blind vaginal pouch given. If this information is given in the question, then have a look at what they are telling you about the pubic hair. If the pubic hair are present, the most likely diagnosis is Mullerian agenesis. If the pubic hair are absent, the most likely diagnosis is androgen syndrome. And remember here that in Mullerian agenesis, gonads are ovaries, which are normal ovaries, and in complete androgen insensitivity, gonads are normal testes. Okay, but these are undescended, normal but undescended testes, so they could be anywhere along the they could be intra-abdominal. These gonads, these testes could be intra-abdominal, they could be in the inguinal canal, they could be underneath the labia also. So the location is, could be intra-abdominal, it could be in the inguinal canal, it could also be underneath the labia. Okay, serum testosterone will give you a fairly good idea. Serum testosterone in Mullerian agenesis is going to be in the normal female range. In complete androgen insensitivity, it is going to be high, very high androgen levels, very. levels in the male range. Okay, karyotype is going to give you the definitive diagnosis. The definitive diagnosis is possible by karyotype. Okay, so Mullerian agenesis 46XX karyotype and with the complete androgen insensitivity XY karyotype. What is the management? See, both of these conditions, the management is along similar lines, right? However, if you look at it, with Mullerian agenesis, they have normal ovaries, they have no estrogen deficiency, right? See, the breast development is normal. So the hormonal profile, the estradiol levels, they are also normal in these both these situations. Okay, so they don't need any hormone replacement. Okay? As far as pregnancy is concerned, it is possible by IVF and surrogacy because they don't have a uterus. They can go for IVF and surrogacy. If you look at complete androgen insensitivity syndrome, again, these are undescended testes. Okay? So they will need gonadectomy. Gonadectomy is done, but after pubertal development is complete. Okay, after pubertal development is complete or after the age of 8 years, once the gonadectomy is done, okay, because these gonads in androgen insensitivity from these testes, they're actually producing androgen and testosterone, which is getting aromatized to estrogen, right? And that is what is driving and that is what is causing the breast development. That is why they are having normal breast development also. So these gonads are contributing to pubertal development in complete androgen insensitivity syndrome. So gonadectomy will be done, but after pubertal development is complete. Once you have removed these gonads, after that they have no source of androgens and aromatization. Then they may need estrogen HRT. As far as pregnancy is concerned, their option is only adoption for them. Okay? So these are important pointers in comparison for Mullerian agenesis versus androgen insensitivity syndrome, on which MC definitive diagnosis is possible. Karyotype, serum testosterone levels can give a fairly good idea. Now, the other important flow chart, must know flow chart, if there is primary amenorrhea and breast development is absent. If breast development is absent, in itself means that there is some estrogen deficiency. That's why breast case, if they give you uterus is present, the next step is basically ideally we go for a complete hormonal. You go for a complete hormonal profile, but if you have to pick one hormone level, pick FSH, pick one, right? Because that will help you streamline the causes. So if your FSH is high, the diagnosis is hypergonadotropic hypogonadism. Okay, then in this situation, the next step is a karyotype because you're thinking about the possibility of gonadal disease, and that you will find only by karyotype. So remember here, if the height is short, if the streak ovaries are given in the question, if hypoplastic uterus is given in the question, then your answer should be Turner syndrome. If the patient is tall with streak gonads and uterus present, then the most likely diagnosis is the other types of gonadal dysgenesis. And to know for sure what is the diagnosis, you will need a karyotype. Karyotype will confirm diagnosis. If your FSH levels are low, then your diagnosis is hypogonadotropic hypogonadism. Okay. Now, in this situation, if they say the patient is tall, she's also having a okay, then your answer should be Coleman syndrome. Right? In this situation, whenever you have hypogonadotropic hypogonadism, we always rule out CNS tumors, right? That could be a possible cause, right? And MRI brain is done for that. And what the most common CNS tumor, primary amenorrhea, right, is craniopharyngeal. This is also important for MCQ, right? And once we have ruled out all other possibilities, we've ruled out any CNS cause, we've ruled out Coleman syndrome. We don't think it is Coleman, right? So the patient is short, other causes have ruled out, FSH is in the low normal. Then you think about delay in constitutional cause of delayed puberty, right? So this is a flowchart that will help attempt questions according to clinical profile if they give you clinical profile, right? Also remember, these are potential new questions, very important. I keep telling you that they've been asking a lot in detail about primary amenorrhea. So let's say you have primary amenorrhea, breast development is also absent, uterus is present, high FSH. You mean to say here, okay, primary amenorrhea, breast development absent, uterus present, high FSH there, right? It is hypergonadotropic hypogonadism. You've done a karyotype is null, but it is not gonadal dysgenesis. Say there is no gonadal dysgenesis, there is a normal karyotype. What can you think of? Think about rare cause now. The rare cause could be any enzyme deficiency. Maybe the gonads are there, but they cannot synthesize the hormone. So think about 17 alpha hydroxylase deficiency. Okay, this is anyways rare. This enzyme is required for androgen synthesis, so that androgen, right? So integrated type of question, especially in INICET, the very potential pass such. Okay, so think about 17 alpha hydroxy. These are required for steroid hormones. It's steroid hormone synthesis. So there can be these rare enzymes. If there is primary amenorrhea, breast development is there, uterus is also, hormonal profile is normal, ultrasound is also. You mean to say nothing has been found? Primary amenorrhea, breast development there, uterus also present, normal hormone profile, ultrasound, nothing there. Okay, no uterine cause found. All the previous causes that we discussed in the flowcharts, they are not there. Then think about what? Then what we can do is, then I'll give you a shortcut. We tend to do a progesterone challenge test. Okay, we tend to do a progesterone challenge. After progesterone, if bleeding is present or if bleeding is absent. Okay, so if bleeding is present, that means that maybe there is a constitutional delay in menarche. Nothing was wrong, just a constitutional delay in menarche was there. Nothing was wrong. Okay, and if the bleeding is absent, then you think about maybe there is the problem with endometrium. Okay, you think about endometrial cause, which is again rare endometrium receptor deficiency. Let's not talk about it. Okay, let's not talk, but rare. Yes, endometrium could be the possible cause. It could be very rare endometrial receptor deficiency, rare endometrial absence, whatever long list given. No need to go there. What I'm pointing out here is in the Indian context, in the Indian context, please think about genital tuberculosis could present with primary amenorrhea as well. Think about genital text as well. Now, let's have a look at the next. This is from the most recent ionized paper. Okay, a patient presents to the clinic with clitoromegaly, prepubertal breasts, and Tanner stage 2 pubic hair. So the prepubertal breasts are there, Tanner stage 2 pubic hair. So pubic hair are also not developing properly. There is a blind ending vagina and there is clitoromegaly. So when you see clitoromegaly, you know that it is androgen. Because clitoromegaly is a symptom of, is a sign of virilization. It is a sign of virilization, meaning excess androgen. Not just androgens, excess of androgen in the body. That's why there is now clitoromegaly. The karyotype is 45 and testosterone levels are in the range of male. Which of the following is the most full diagnosis? Now let's just eliminate and then we're going to talk about this in slightly more detail to help you attempt questions. Okay, so with complete androgen insensitivity syndrome, remember here, okay, the karyotype is 46XY even with complete. Actually, in all of these situations, karyotype is 46XY. In all of these situations, the gonads could be testes. Okay, but with complete androgen insensitivity syndrome, the breast development is normal. Okay, breast development is normal. So I will not say this is the answer. With Swyer syndrome, the 46XY type of gonadal dysgenesis, okay, the gonads are dysgenetic. So they were not producing androgen. So Swyer syndrome, there will be no action of excess androgens or anything. Okay, because in Swyer syndrome, the gonads are dysgenetic. They are not producing excess androgen. They will not have signs of excess androgen. And the uterus is present. Anyways, the uterus is present. We just discussed. Swyer syndrome is not the answer. The uterus is present there, and therefore there will not be a blind ending vagina. Now, option C and D, 5 alpha reductase deficiency and 17 alpha hydroxylase. With 17 alpha hydroxylase deficiency, I am just eliminating. So you have to know the basics. Without knowing the basics, such questions cannot be attempted. That becomes difficulty level. That is why this is a difficult question. 17 alpha hydroxylase is an enzyme which is needed for steroid hormone synthesis. It is needed for androgen synthesis. Androgens are needed for estrogen synthesis. Okay. So if this enzyme deficiency is there, androgen synthesis will be deficient. Androgen synthesis will not be there. This will not be there. Androgen synthesis will not be there. So how can there be clitoromegaly? Okay, so how can there be clitoromegaly? How can the testosterone levels be in the male range? I have eliminated. I have simply eliminated option A, B, and D, and left with 5 alpha reductase deficiency. So 5 alpha reductase is an enzyme that is required for conversion of testosterone to dihydrotestosterone. Okay, so if this 5 alpha reductase deficiency is there, then what will happen? DHT is not getting the 5 alpha reductase deficiency. DHT is the one that is going to be responsible for pubic hair development. So that is why pubic hair are, but because of the high amounts of testosterone that they have, okay, they can have features of testosterone. They can have features of androgen with that also. 5 alpha reductase deficiency. Answer here. So far, I have taken up the profile. I have not gone into too much details. I have attempted this question right now only by eliminating, only by applying logic. Okay, but if you want to go deeper into the understanding of what is happening in these clinics, we'll have to just briefly talk about what are these situations. Okay, what are these situations that they are talking about, and they are framing questions. Basically, disorders of sexual development, disorders of, they're framing questions on disorders of 46XY sexual development. Okay, so basically it was a 46XY fetus, okay, with an SRY gene that was there. Okay, this could be defective. Okay, this is what happens in a 46XY fetus. The gonads become testes, Sertoli cells secrete AMH, Mullerian duct regresses, Leydig cells secrete testosterone, Wolffian duct develops into internal genitalia. 5 alpha reductase converts testosterone to DHT. DHT is responsible for the masculine, the external genitalia, and the male phenotype, male external genital development. This is normal. What happens in disorder? In disorders, there could be, defect in the SRY gene. Okay, the gonads don't develop into testes. So one could be gonadal dysgenesis. 46XY type of gonadal dysgenesis, Swyer syndrome. The gonads did not develop into testes. There were no AMH in Sertoli cells. Mullerian duct doesn't regress. Leydig cells don't secrete testosterone. Wolffian duct doesn't develop. So basically, what happens is a female phenotype, female internal and external genital. Basically, what happens is female internal and external. Yeah. For quick recall, just remember that the default genitalia of a fetus or the default sex of a fetus is female, right? So if it cannot go along the male direction, it is going to go along the female direction. So in this particular situation with gonadal dysgenesis like Swyer syndrome, it will be female internal and external genital. The other thing could be that the gonads are testes. Yes, maybe the testes, right? But they are not able to synthesize testosterone. Maybe they are not able to synthesize testosterone. So the second thing could be testosterone, or let's say androgen synthesis deficiency, maybe some rare enzyme deficiency because of which the gonads can't synthesize androgen. Okay. Then the third possibility could be that testis is there, testosterone is getting secreted, but androgen receptors are deficient. Androgen receptors are deficient. That means androgens are there, but they cannot act. So that is androgen insensitivity syndrome. Androgens are there, but androgen receptors are deficient. That is the third possibility. The fourth possibility that I will tell you is that maybe there is 5 alpha reductase deficiency. So if there is 5 alpha reductase deficiency, then you can see here 5 alpha reductase deficiency. DHT won't be there. External genitalia will not masculine. External genitalia can be female. But what about internal genitalia? Internal genitalia is going to be male because the Wolffian duct development requires testosterone. So even if there is 5 alpha reductase deficiency, external genitalia will fail to masculinize, but Wolffian duct will develop into the male external. So internal genitalia will not be off. Okay. Slowly we are going to cover this very important high yielding points I'm giving you. Okay. So when you have rare causes like testosterone or androgen synthesis deficiency, or you have 5 alpha reductase deficiency, it becomes difficult to mug up the entire thing. But once you know the logic, you can eliminate from the option. Now, remember here one more thing. I will give you a flow chart again to help you understand. Okay. So, see, Swyer syndrome, complete androgen insensitivity syndrome, androgen synthesis deficiency, 5 alpha reductase. They are summarized in one place. I'll tell you what are the key important. See, with Swyer, you have dysgenetic testes. With Swyer, you have dysgenetic testes. We've already told that here. Testes are not there. Dysgenetic testes are. We've discussed Swyer in the previous question. Gonadal dysgenesis. 46XY gonadal dysgenesis. Okay. Now, the location can be intra-abdominal, mostly intra-abdominal. It can be in the canal also. The uterus reductase deficiency. Look at the common things. Look at the common AMH and Mullerian duct regress. Look at this undescent. Okay, so look at this. What happens? Uterus absent because Mullerian duct regress. Mullerian duct regresses. Okay, but what about the external genital? Female, androgen receptor deficient. Androgen. If androgen synthesis is not taking place, deficiency, then the external genitalia can be female or ambiguous. Now, why have I written ambiguous there? I've written ambiguous there because depending upon whether this deficiency is complete or partial, complete enzyme deficiency, complete receptor deficiency, so that is a complete androgen insensitivity syndrome. Phenotype is female, external genitalia is female. With partial androgen insensitivity syndrome, you can have ambiguous external genitalia. Okay. With androgen synthesis deficiency, if it is partial, then ambiguous genitalia can be there. With 5 alpha reductase deficiency, external genitalia can be female if there is complete 5 alpha reductase deficiency, or it can be ambiguous. That depends. All right. Most of the times, your clinical question will be like this: female phenotype. So, what do we see? What similarity do we see? The similarity that we see is that such individuals with 45 disorders of sexual development, they are born and brought up as females. 46XY disorders of sexual development, born and brought up with these subtle differences as mentioned. Okay, now again, like I tell you, it becomes difficult to mug up the table. That's why it is more important to at the end, right? And that's why we went through this chart. We went through an example question asked in your exam to help you understand how to go about eliminating options. Okay, now also remember, I'll give you a shortcut now that I have explained to you how to use this. Let's have a look at a short. If you're given a profile of a young girl with an inguinal or labial mass, important potential question, inguinal or labial mass in a young girl is most likely going to be an undescended testes. You think about the possibility of descended testes, especially in the setting of primary amino. So this would be the profile. Okay, start here. Then look if the uterus is. The moment that you see an undescended testes, of the possibility of undescended testes, this inguinal or labial mass will never be an ovary. Ovary will never be here, right? The moment that you see this, you know that you're talking about 46XY disorders of sexual development. Then the uterus is present and the pubic hair is present. Your answer is fire syndrome. Pick this as the, because this is the only condition where your uterus. Now, this is going to be a phenotypic female. Remember, we've discussed this with 46XY gonadal dysgenesis and the profile of gonadal dysgenesis, which we discussed in the previous section, in the previous question, right? Pick that as the. If you have uterus absent and pubic hair also absent, look at this. Pubic hair are androgen dependent hair. They need androgen. So androgen should be there and androgen receptor should also be. So when you have pubic hair absent, you're thinking about all of these three other possibilities. How do we eliminate? Okay? Look what they're telling you about breast development. If they're saying that breast development is present, answer is complete androgen insensitivity syndrome. Okay, that should be your answer if breast development is present. If they're saying breast development is absent, okay, then if they say that there is no virilization, breast development absent but no virilization, that means androgens are deficient. That is why no virilization. That is why breast development is also not there. Na? Androgens can get converted into aromatase. That will lead to breast development. So breast development absent, no virilization, nothing. It is androgen synthesis deficiency, hypergonadotropic hypogonadism. This was a question in your NEET PG. Most recently, they are asked same profile and answer was androgen hypergonadism, hypogonadism. Type of hypogonadism, though rare. If your breast development is absent and you have virilization, if you have virilization, then there are two possibilities still. One is 5-alpha reductase deficiency. One is partial androgen insensitivity. Okay. In your exams, like for example, in this particular question, answer was 5-alpha. Partial androgen insensitivity not given in the, was not given in the option. The confusion did not arise. If they want you to differentiate between 5-alpha reductase deficiency versus partial androgen, they will have to give you the information. They will have to give you other information. Like for instance, with 5-alpha reductase deficiency, the serum testosterone levels are going to be elevated and the DHT levels are going to be decreased, right? So this ratio is going to be high. This ratio is going to be. With partial androgen insensitivity syndrome, this ratio of serum testosterone and dihydrotestosterone levels, this ratio is going to be. With complete androgen insensitivity, the serum testosterone levels are high. They are also in the male range. The DHT levels are also high in the male range, just like, right? But breast development, right? With androgen synthesis deficiency, you can understand that androgen testosterone levels are female range deficiency, right? So remember this. Okay, this is the shortcut. Now let's have a look at the next question. Which of the following drugs not used in PCOS? So the answer is tamoxifen. Clomiphene citrate can be used as an ovulation induction, right? Metformin is used as an insulin sensitizer. Ocipil is used to regularize the cycles. Ocipils help with the regularize the cycles. Ocipils help with the hirsutism also, right? So all these are used in. And remember that the drug of choice for ovulation induction PCOS is letrozole. That is an aromatase inhibitor. Is the first choice rather than clomiphene. Tamoxifen does have some in the past it does have some ovulation induction properties. Not used. Not used in PCOS management. We are not using it. Okay, we are not using this management. So that is the best choice answer to the question. Don't get confused, because if you read the textbook, tamoxifen is also a selective estrogen receptor modulator. Clomiphene is also selective estrogen. Tamoxifen have ovulation induction. It's not used in clinic. Okay. Next question. A 26-year-old woman with a BMI of 30, that means she's obese, she presents to the clinic. She also has a history of fertility for the past 6 years. On physical examination, hirsutism is noted. What is the best next step? So she has infertility that has to be dealt with. She has some mild hirsutism. Right? What can be done? Unfortunately, you see, the drugs that are used for hirsutism, the drugs that are used for hirsutism, those drugs cannot be used while she is trying to get pregnant. Interesting. Let's see how. See, what will she be required to do? She will be counseled weight reduction, yes. Metformin as an insulin sensitizer, yes, because the profile is fitting that of a PCOS patient. Metformin for insulin sensitizer, yes, it can be given. That will be done. Ovulation induction. Because infertility for past 6 years. That's a right. So ovulation induction with clomiphene. First line, we are going to try letrozole or clomiphene. Gonadotropins, GnRH analogs in the pulsatile form, they're all second line ovulation, right? So first line, yes. Weight reduction plus metformin plus ovulation induction with clomiphene. Now, uh, for her mild hirsutism, if you think that you should give finasteride or finasteride, the question that they had asked, the intention of the question to test whether you knew this, that these anti-androgen drugs, you have these finasteride and flutamide also. Finasteride, flutamide also. If a woman is given these drugs, they can cross the placenta. And if it is going to be a male fetus, they're anti-androgen. If she conceives, and she has a male fetus, then they can interfere with the sexual development. Right? They can interfere with the sexual. So, for a woman who is wanting to conceive, you can't give finasteride. So, if you're planning to give her ovulation induction for infertility, you can't and you should not give finasteride along with it. Out. Even if you're telling her, okay, try for spontaneous conception, then also you can't give her finasteride or anti-androgen drugs for hirsutism because of this potential risk. So option number C and D are out. Now, If you try to treat her hirsutism with oral contraceptive pills, then she can't be pregnant on that. So we have to strike a balance. So what balance did we strike? We started with weight reduction, metformin, ovulation, and and for the clinical hirsutism, can call for cosmetic treatment, right? So use logic and use all questions be easy conception, especially not, right? Keep that in mind. Now, let's have a look at the next question. In a young female with prominent facial hairs presented with PCOS, first line of management, she has PCOS, she has some, hirsutism also. First line management always going to be the line of management, first line management, always in PCOS, always lifestyle. Okay. Then, as far as the drug treatment goes, possible the cycles as well as to deal with mild hirsutism. Know that the drug of choice for mild hirsutism is actually oral pills, especially have a clinical trial of PCOS, then it can help regularize the cycles, also take care of. So OC pills, yes, use lifestyle management, yes, done. Anti-androgens, they are second line. Na? Second line drugs are there, like anti-androgens, spironolactone, second line. And then you have the other anti-androgen like flutamide and finasteride. So they can be used. They can be used. Yes, they can be used. Laparoscopic ovarian drilling is something that is described, yes, in textbooks. It is has very limited practice because laparoscopic ovarian drilling is going to compromise the ovarian reserve. So it can compromise the ovarian reserve, right? It was used earlier, yes, in resistant cases. It was used in resistant cases of PCOS, especially in women who were not able. And but nowadays, with IVF and with advancement in IVF, the need for laparoscopic ovarian drilling is actually reduced. So we're generally not doing it. So as of now, the line of management becomes the 1, 2, and 3. I'm okay doing lifestyle management, anti-androgen I can think of. Laparoscopic I don't prefer. The young female. Okay, so this is something that I would not go for any first line at all. So answer is 1. Now, remember here some key important pointers with HER2, right? So, when you have a clinical case or clinical system, make sure that by history or by any other finding given in the maybe a clinical finding or maybe a history suggestive of hypothyroidism or hyperprolactinemia. Make sure that you rule, especially if menstrual irregularities are there, especially if menstrual irregularities are there or ME is also there. Rule out hypothyroidism, and one should also rule out hyperprolactinemia, the common endocrinological causes associated with hirsutism also associated. And one also checks the serum testosterone levels. One also checks the serum testosterone levels. If it's mild chronic hirsutism, slowly progressive, and it has been there for a long duration of with menstrual irregularity that has been there since, serum testosterone levels are high but they are less than 150, then you're most likely diagnosed. Okay? With PCOS, the serum testosterone levels are high. They can be normal also, but they're not going to be very high. But if you have acute onset of autism, acute, sudden, severe, rapidly progressive, or your serum testosterone is also, very high, more than 150 million, then you always think about and rule out the tumors and adrenal gland tumors also. With adrenal gland tumors, DRS will be specifically raised with adrenal tumors. Keep in all. Okay. Now, and when you have ovarian tumors which are androgen secreting, like certainly Leydig cell, these are sex cord trauma. The age group profile of the woman, late 30 age profile will do with the diagnosis. In pubertal girls, very severe. right? Also consider the possibility non-classic type congenital adrenal hyperplasia, congenital adrenal hyperplasia, and in the question look for the diagnostic criteria. If they say raised 17 hydroxy, that clue will be there, keep that in mind. Now let's have a look at the next question. Now the next question is regarding the pathogenesis of preeclampsia, which of the following is incorrect? Incorrect you have, right? So increase in SFLT1 and decrease in placental growth factor. So these are the anti-angiogenic factors which are increased, and these are the angiogenic factors which are increased, right? So this is true, correct. Vasoconstriction leads to ischemia, necrosis, hemorrhage, and end organ damage. Preeclampsia, true, right? So there is vasoconstriction which also leads to hypertension. The generalized vasoconstriction also. Endothelial cell dysfunction, endothelial damage is the second piece of, yeah, and there are reduced nitric oxide levels. You know that nitric oxide is synthesized from cells. Nitric oxide is a vasodilator. Endothelial cell dysfunction leads to reduced nitric oxide levels, right? Nitric oxide is a vasodilator. Reduced nitric oxide, vasoconstriction. This is also, so A, B, C true, D is the incorrect statement, D is the false statement. There is decrease in thromboxane A2. Thromboxane A2 is potent vasoconstrictor. It is reactivating platelets. So if there is vasoconstriction happening, I say that the thromboxane levels increase. So thromboxane levels increase, and prostacyclin PGI2 is a vasodilator. So obviously the vasodilator prostacyclin decrease. So what happens to the ratio? The ratio decreases. The ratio decreases, right? So logic and concepts, option number D is incorrect, right? So they're asking you a lot of questions on the pathophysiology. Pointer here. Recently in May 2020, there is an FDA approval for a test that took place, that is SFLT1, SFLT1, and placental growth factor, serum SFLT1 and serum placenta. Hmm. This ratio more than or equal to 38 to 40%. Okay, this ratio, if you can see here, if SFLT1 increases and placenta, this ratio change, right? So we say that a ratio of more than or equal to 38 to 40% is predictive of eclampsia, but the utility is limited. The utility is, let's say, in women who have hypertension, pregnant women who have hypertension, but we are not sure if it is pre admitted between 23 to 35 weeks, and we are not sure if they are having preeclampsia, then we can use this test or this ratio to check if they are at increased risk of developing severe preeclampsia. Then we check if they are at increased risk of severe preeclampsia. That is the utility of this. Recommended and approved by FDA, not for all patients, not routinely for all patients. Pregnant patients who have been admitted with, and we need to find out if they are at increased preeclampsia and we are unsure if they have pre. Then this test has utility and it is being approved. This is something new and a potential. Next question. Which of the following is incorrect statement regarding magnesium? Straightforward question. Magnesium sulfate should be given for 20 hours after convulsion or delivery, whichever is later, whichever is later, right? So this seems like a true statement. Magnesium sulfate in renal failure. See, women with preeclampsia, severe preeclampsia, eclampsia, they can have, renal disease, right? Now, even in the face of renal dysfunction, even in the face of oliguria, even in the face of renal failure like findings or raised serum, at least the loading dose can be given. Maintenance dose will be adjusted based on renal. So renal function means serum creatinine. Renal function means serum creatinine. Serum creatinine levels are used. Let's say, for example, if a patient is having oil, if there is a preeclampsia, severe preeclampsia or eclampsia in magnesium, right, and there is oliguria, if there is oliguria, then we have to check the serum creatinine level to see if we can continue giving magnesium or to adjust the maintenance, right? So loading dose can be safely given. So that is also true. Magnesium sulfate is a neuroprotective drug. That is also true. It has anticonvulsant property. It has a centrally acting anticonvulsant role. See, the convulsion with eclampsia is self-limited. Convulsion with eclampsia is a generalized tonic-clonic. It lasts for about 1 to 2. Giving magnesium sulfate does have anticonvulsant properties. It role. So actually the use is that it prevents any further. It prevents any further convulsion in a patient who's already had a convulsion, like eclampsia. And again, we are giving it eclampsia first to prevent convulsion. That is the role of magnesium. It covers seizures, but does it cover hypotension? It is not a antihypertensive. Please remember. With magnesium sulfate, there is some vasodilatation, that is some flushing also because of that vasodilatation. BP can also fall a little bit while giving magnesium loading dose, but it is not used. Please remember, magnesium sulfate is not anti. If there is hypertension, labetalol, IV labetalol is the drug of hypertensive. Know that IV labetalol, hypertensive, and for otherwise also oral drug also labetalol is the drug, right? So it is not an anti-hypertension. For hypertension, you so option number C, the incorrect statement here. C, correct statement. Next question. Regarding management of diabetic women, which of the following is incorrect? See, interesting. Elective cesarean section has no effect. So, in diabetic pregnant patients, in diabetic pregnant, we are especially because of the risk of macros, especially because of the risk of if the estimated weight is more than 4.5 kg, it has been suggested that offer elective cesarean section, right? Offer elective cesarean. To do what? To decrease the risk of or possibility of shoulder dystocia. This has been suggested. This is something that is generally offered. But the studies have shown, the evidence is there, that even if we do elective cesarean section in all cases, it really does have no effect in incidence or of brachial plexus injury, because even during cesarean section also, brachial plexus injury can while conducting a difficult cesarean. Also, shoulder dystocia can happen even normal weight babies also, right? So macrosuria is a risk factor for maternal diabetes is a risk factor for but shoulder dystocia happen in average weight babies also. So doing elective sections all the time actually has no effects in reducing incidence of brachial plexus injury. That is a true statement. Okay, GDM patient should be given morning insulin dose. Why? If we are going to give the morning insulin dose at the time of understand here that if there is a patient on insulin, whether that is patient whether that is patient diabetes, remember here that the nighttime dose is given. The nighttime dose is right, but the morning dose, the morning insulin is omitted. It is not given. Why? Because now we are inducing, or let's say we are doing an elective cesarean section, even the morning dose is omitted, because during the course of labor, the patient diet will be restricted. She will be on fluid diet. Okay, she's a high risk candidate cesarean section. Or if we are planning an elective cesarean, she will be nil parod. Why will we give more? We will adjust her insulin up. So we have to titrate the insulin according to the blood sugar. That is why regular sugar charting, blood sugar monitoring is done. Blood sugar monitoring is done for every 1 to 2 hours, and insulin dose, which is regular insulin, is titrated. Ideally, it is given by infusion. Otherwise, sliding scale can also ideally given by infusion. Slide. So remember that the morning dose is not given, it is omitted. So that is why option B is incorrect. Option B is the false statement. Option B is incorrect. Regular insulin given by IV ideally. So this is true. And the goal is to maintain the capillary blood approximately. That is also true. So we don't want hyperglycemia during labor. We do not want maternal hyperglycemia during hypoglycemia. Need the average capillary. True, because why? Remember here that maternal hyperglycemia. Remember here that maternal hyperglycemia during labor in diabetic women increases the risk of newborn hypoglycemia. Remember. And also remember that after delivery, the insulin requirement, if she's already on insulin requirement, right? So keep that in mind. We will not need as much insulin as she did during the delivery. Accordingly, then after also in these patients. That next question: which of the following is responsible for fetal heart rate excellence? Okay, so it is the autonomic integrity. It is the integrity of the autonomic nervous system. Autonomic nervous system integrity or autonomic function of the brainstem, which is responsible for fetal rate excellence. Remember that, right? So there is this the vagal stimulation, which brings down the fetal heart rate, and there is sympathetic stimulation, the fetal, this pull and tug of the, let's say, push and pull of the parasympathetic and the sympathetic, that is responsible for the fetal acceleration. Also, this is responsible for the beat to beat variability. Also, this is responsible for the reactive NST. That's what it means, heart rate, right? Now, carotid baroreceptor, aortic baroreceptors. Let me also tell you also that your late decelerations, which you see with fetal hypoxia, remember that late deceleration, type 2 deceleration, yeah, they are mediated by chemoreceptor reflex. So that is why, with hypoxia and acidemia, they are chemoreceptor mediated reflex. Okay? And your variable decelerations, which happen because of cord compression. Okay, because of cord compression, if the fetus's umbilical cord gets compressed, then the umbilical vessels get. When the umbilical vessels get compressed, these are the vessels which are taking blood away and towards the baby. Right? What happens? Blood pressure. Okay, with cord compression, the blood pressure changes. Fetus, right? So they are basically baroreceptor mediated. Right? So this is the INICET went one step deep in asking. And also you have the early decelerations, which are because of head compression. Because of head compression, there is vagal stimulation, and that is responsible early. Right? So these just for MCQ. Next question: a 32-year-old woman visits the OP with history painless ulcer on the vulva. Her obstetric history reveals history of stillbirth at 28 weeks. She has got contact with multiple sexual partners. Next best step. So many clues in the question. Now there's this painless ulcer on the, if it's a painless ulcer on the vulva, you think about the history of stillbirth. Syphilis also most likely causes stillbirth. At stillbirth at term or stillbirth at later in gestation. History of stillbirth. It's also sexually transmitted infections. History of partners all go in favor of syphilis, and that is why you have to for VD testing. You can screen with VDRL. If the VDRL is, you have to FDA app steps. Right now, HIV ELISA is also done whenever we test for sexually transmitted infection. Simultaneously, we test for HIV. But you see, HIV is not fitting the picture now, because with the history of stillbirth, otherwise HIV is not a teratogenic. HIV is not a teratogenic virus, and it is not associated with portion. Then lupus anticoagulant. Lupus anticoagulant is associated with APLA, you know, pregnancy eclampsia also can cause and complications at venous. So APLA can have a similar profile, but ulcer. Why ulcer in APLA? Right. So that is why lupus anticoagulant is not here. So VDR testing is the answer. Next question. What is the best treatment for osteoporosis for a woman 60 years? They're asking you the best treatment. Osteoporosis already set in, you see. The drug of choice is bisphosphonate. You will obviously go for calcium supplement. You will give vitamin D supplement. So, right? But the drug of choice is bisphosphonate for a, the estrogen therapy. I will not estrogen therapy as therapy for osteoporosis. The estrogen therapy or hormone replacement defense against osteoporosis, provides protection against osteoporosis. But the age of the woman, 60. In this age, giving HRT is dangerous because HRT is the risk of coronary artery disease. So, estrogen therapy is not therapy for. Keep that in mind. Drug of choice for established osteoporosis, bisphosphonate. Now, which of the following is a true statement for HRT? HRT decreases breast cancer. HRT decreases endometrial cancer, colon cancer. So I just now told you that HRT will prevent osteoporosis. It has protective effects against. So this is false statement. It decreases the risk of colon cancer. That is the HRT, any form of HRT. So HRT, current use of HRT, particularly the progesterone HRT, it actually increases the risk of cancer, decrease. Whenever we are giving hormone replacement therapy causal patient, see, we are giving estrogen along with progesterone endometrial protection. Even when we give progesterone for endometrial protection, right, the risk of endometrial cancer is still there because we are giving estrogen also. I mean, we are giving progesterone for endometrial protection, right? But any HRT, please, any estrogen, please remember, will increase the risk of endometrial cancer with HRT. Or it increases the risk of cancer. Don't think that just because we are giving for endometrial protection, but 100%, is it going to decrease endometrial cancer? No, it is going to provide protection, degree of protection, yes, but it is not going to decrease the risk of endometrial cancer. With HRT, the risk of endometrial is increased. Remember that also. So remember, they have asked you questions, right? So HRT provides relief from hot flashes. In fact, for hot flashes, this is the most common indication for use of HRT in post HRT in post women, right? It will help provide relief from genitourinary atrophy, atrophy symptoms, help in prevention of osteoporosis, decrease colon cancer. These are definite advantages. If you look at the disadvantages, there is increased risk of coronary artery. In older women, risk of breast cancer is there. This is particularly because of the progesterone complex. Risk of venous thromboembolism is also there. It is not there with transdermal estrogen. It is, but not there with transdermal estrogen. Risk of endometrial cancer cancer. Disadvantage HRT. So remember some important pointers here. For postmenopausal HRT, present we give estrogen. If uterus is present, we don't, except when there is a hysterectomy or endometrial cancer or endometriosis, or meaning except when there has been a history of estrogen dependent condition, right? If estrogens are contraindicated, SSRIs can use. One drug that is FDA approved for this purpose is okay. If there is only complaint of vaginal dryness, then local estrogen creams are, there's no need to give system, right? So the most common indication for systemic HRT is hot or vasomotor with most postmenopausal women. There is another SCRM, that is osmocotin. It is an SCRM for dyspareunia due to vaginal dryness. But please remember, tamoxifen and raloxifene are for treatment. They actually as a side effect. And future HRT is conjugated equine estrogen SCRM, which being done. And the drug of choice for osteoporosis, like I told you, is bisphosphonate. Keep that in mind also. Next question: which of the following drugs is not used in the management? So estradiol. See, endometriosis is a condition which is estrogen dependent. So why would I use estrogen management? Right? Right. So endometriosis management. Remember here that drug management is the treatment. Right. So what can we do? We can give oral contraception. So they have a role. Oral contraception. Oral contraceptives are more progestational, right? So they are used progesterone in the form of hydroxyprogesterone, right? Then leuprolide is a GnRH analog. GnRH analog can be used for suppression of ovarian hormone. Endometriosis patients, they also often require ovulation in for their fertility, for their infertility. So clomiphene citrate will have a role in the endometriosis. Survival estradiol have a role, right? So clomiphene can for ovulation in even other drugs for ovulation. Estradiol will not management of this. That is going to be the cure. Okay. Now let's have a look at the next question. Now unicornuate uterus can be identified by. This was an interesting question, and that is why I picked up. Also, a lot of questions are being asked, right? So we're going to take up important points there also. So unicornuate uterus can be identified by their multiple choice. So X-ray pelvis by itself is not an idea. So that out laparoscopy, yes, HSG does give an idea. What is phalloscopy? Now, phalloscopy is uh, phallop is for the fallopian tube. When we say hysteroscopy, is looking inside the uterine cavity. Phalloscopy introduce this, a very thin scope along the inside of the fallopian. So from the inside of the fallopian tube, this tubal opening here, colostia here, to the inside, we can introduce a phalloscopy. So technically, yes, phalloscopy, what would we do is that we would, if we were to go inside the uterine cavity, if it's a unicorn, we would find only one tubal opening, isn't it? We would not find the other tubal. So phalloscopy could be. That's why multiple choice correct could be. That is why this was also the correct answer. Unicornuate uterus can be identified by phalloscopy. Just let's have a look at the HSG. So this is the HSG image showing unicornuate uterus, as you can see, right? Only one side paramesonephric duct or Mullerian duct, at the other side, right? And you can see here there may be a rudimentary horn. There may be a rudimentary. This is uncommon but possible. If this rudimentary horn is functional, okay, then there can be complaints like unilateral dysmenorrhea, or there can be also a cornual pregnancy. What is a cornual pregnancy? A cornual pregnancy is a pregnancy in the rudimentary horn. That could be there, rare but possible. The rare but possible present. And don't forget the most common presentation of Mullerian anomalies on the whole is second trimester pregnancy loss, right? Recurrent pregnancy, right? Okay. Now let's have a look at this. Again, septate being the most common. So which one is septate here? You can see here this one is septate. Septate is overall the most common, and this one is bicornuate. So you can see here there is a dip at the fundus with bicornuate. With septate, there is no dip at the fundus. HSG image will give you an idea, not confirm. So this is likely septate. This is likely septate because you can see the angle is, and the distance between the two horns is less than 4 centimeters. This is likely bicornuate. I'm not 100% sure. This is likely bicornuate because of the angle that is obtuse and the distance between the two horns. So it's not possible to measure the distance of the image, but it is possible to see the angle. So focus on the angle. So acute angle, if you see, likely septate. If you see angle, likely bicornuate, right? And for the dip in fundus and for the intact fundus, the diagnosis can be 100% confirmed by best or gold standard confirmation. Best or gold standard confirmation is lapro plus histro. Lapro plus histro. Okay, because inside it is going to be the same, right? There's a single cervix and there are two uterine cavities. Two uterine cavities in a single cervix. Best is laparoscopy plus hysteroscopy because that way we can see the fundus also. Look at this. This is a diadelphys uterus. Diadelphys uterus. Okay. Now in a diadelphys uterus, what do we see? There's a dip at the fundus also. And you can see here that it is entirely duplicated. Okay, there is two cervix and there is two uterus cavities. Okay, so two separate uterus cavities and two separate cervixes also. So on per speculum examination, you will see two cervix. On per speculum examination, you will see two separate cervix. That would be your clue. In an HSG image, maybe there are two cannulas. Maybe there are two HSG cannulas, shadow of two HSG cannulas that you can see. That will help you make the diagnosis. Two cervix, focus on that, two cervix, right? So they can give you this information that per speculum examination, there are two cervix, or on an HSG film, you can see shadows of the cannulas. Okay? Cannulas that are in making the, uske saath you will feel that, okay, if there are two shadows of the cannula, that means there are two cervix. Then your diagnosis is diadelphys. So please remember here, very, very important. Please remember, very, very important. That if they ask you the investigation of choice, if they ask you the first investigation, you see, we begin these days with 3D ultrasound, 3D USG. Please remember this also. Okay, we don't straight away go with laparohistory. Please remember this. It is a gold standard, but a non-invasive test can be done. Let's say there is a woman with history and pregnancy, and you want to make a diagnosis, you want to screen to find out if there is a Mullerian anomaly, then start with 3D ultrasound. Okay, MRI is better. MRI is definitely better, but MRI is expensive. And MRI now is used when the diagnosis cannot be. So if ultrasound is inconclusive, or we want to simultaneously find out renal anomalies, then we use MRI. So investigation of choice nowadays, in the first investigation to begin with, is a 3D USG when talking about Mullerian anomaly. Keep that. Next question. Additional factors seen in a patient with this karyotype. Now, what is this karyotype? Have a look at this karyotype. Just have a look at the karyotype. See, what do you see? What do you see? We see two X chromosomes and we see Y chromosomes. So we see 47 XXY. So we're talking about Klinefelter syndrome. Talking about, so in Klinefelter syndrome, it is syndrome where there is primary testicular failure, there is male infertility. But even before that, there is, delayed pubertal development. Even before that, there could be delayed pubertal development. Male, there could be male infertility also, right? The male is tall and has gyneco, short limb, web neck. This is Turner syndrome talking about, right? Polydactyly, sandal foot, we're talking about Downs, right? So tall and gynecomastia, we are thinking about Klinefelter syndrome. Another clue that we see is because of primary testicular failure, they have atrophic testes. They have small atrophic testes, right? Which can be judged on clinical examination itself, on total examination can be judged. Small atrophy is primary testicular failure. They are going on deficiency. So remember, they are asking you questions on male infertility. So please remember here that whenever you have azus, remember here whenever you have, yeah, right, then ideally we go for the full hormonal profile, right? We go for the complete hormonal profile. Okay, but if you have to pick one, they're also fond of picking one, then FSH helps you differentiate. Please remember, make a side note, FSH helps you differentiate between obstructive versus non-obstructive azoospermia. Okay, that is if you have to pick one value. Ideally, we go for a full hormonal. So azoospermia is absence of sperms in the semen sample. Absence of sperms in the semen. Okay, so if you have increase in FSH and decrease in serum testosterone, we're talking about primary testicular failure. In this situation, we do a karyotype also. Karyotype to check if there is Klinefelter. I told you what are the findings with Klinefelter syndrome. Okay, right. We also check for Y chromosome microdeletion. Make a note of this. Y chromosome, they can also private testicular. Apart from all the other causes of testicular, which can be radiation, use damage, or traumatic testicular injury, that can also lead to. So we check for Y chromosome microdeletion. So because these microdeletions, they can be transferred to the offspring. So if a male has these microdeletions, then if this person's sperms are used um, IVF baby, then this person could transfer his offspring. Offspring could also later on. So Y chromosome microdeletion counts for counseling reasons, right? If the FSH levels are also low and if the testosterone levels are, this is the rarest, this could be because this is unlikely because in males hypothalamic or pituitary causes are the least common. Okay, hypothalamic or pituitary the least common. The other thing could be that the hormone levels are all normal. If the hormone levels are all normal, we are thinking about obstructive causes, right? Then we have to go for a transrectal ultrasound. Transrectal ultrasound, we can see the male internal genital, right? So obstructive in the epididymis. So that needs to be obstructive, will be having to see the first we are going to see that hormone level, then we say it is obstructive azo. Remember this broad out, and also remember here one more important, that when you have please remember this, when you have azo and you have low fructose low fructose in the semen. Okay, when you have low fructose into the semen and you have acidic pH of the, okay, then you check if there is seminal vesicles dilate, if the seminal vesicles dilate, okay, then you think about the possibility of ejaculatory duct of, if the seminal vesicles are absent, the seminal vesicles absent, Okay, and also it becomes clinically possible to, let's say you are not able to palpate vas, not palpable vas deferens. Vas deferens can be palpated clinically also. So vas deferens is also not palpable. Seminal vesicles are this kind of information. Then you're talking about congenital bilateral of vas deferens. This is also a type of obstructive azoospermia. Obstructive azoospermia. Then all these individuals should be tested for. They should be tested for CFTR gene mutation with cystic fiber. Okay, so not all men who have CP will have this mutation. Not all men who have cystic fibrosis will have congenital bilateral sense of vast difference. So it is not absolute. 100% नहीं होता है. What happens is that it is associated congenital bilateral associated with CFTR gene, which is associated with cystic fibrosis. So test for that. Maybe you can identify, right? And the third possibility is that nothing of this sort, none found. None found, then there could be retrograde ejaculation. There could be retrograde ejaculation. That means the ejaculation is happening on ejaculation, the semen, the urinary. So we have to go for post ejaculatory urine analysis. Maybe there is retrograde ejaculation, meaning that at the time of ejaculation out is going inside the urinary bladder. So such patients also have low volumes. They also have low volumes. All of these three profiles will also have low volume. Last important pointer before I end up at again, because what is about Carter-Jenner syndrome. Carter-Jenner syndrome. Okay, now this syndrome is also called as immotile cilia syndrome. Immotile cilia syndrome. So in this situation, you will not find hormone abnormality, right? What will you find? You will find immotile sperms. You will not find azoospermia. You will find immotile sperm, not azoospermia. Okay. So Carter-Jenner syndrome is immotile cilia. What is a part of this syndrome? Male infertility, right? Male infertility, situs invertus, male infertility, situs invertus, and lung infection, recurrent lung recurrent lung infections, I'll see, right? So recurrent bronchiectasis there. So remember these for MCQs. And with this, we are going to wrap up the session today. And these are the important high yield areas which we have as far as INICET. So the high yield areas and the often see when I discuss the questions also, I took up questions which, like for instance, PCOS they're asking. Now they're asking in-depth questions. They're asking in-depth questions on male infertility, primary. These are the key important areas where they have been repeatedly asking most important areas that revising also before your exam. So these are the areas from which a question can definitely this we wrap up the session today. Thank you so much.